Hello, this is Susanna May, and I am recording my video presentation for MSN 611 Pharmacology. The patient I chose is the 21-year-old male with fever and respiratory distress. Chief concern would be fever and respiratory distress. HPI is 21-year-old male presenting to the emergency room with fever, respiratory distress for 2 days. Patient complains of increased shortness of breath, was ambulated and had fallen. He was found on the floor and had been there for an unknown length of time. Patient presents awake but lethargic, skin pale and diaphoretic. He complains of productive cough with yellow flame and chest pain. EMS states that his initial SATs was 88% on room air. A duodeneb was given en route and SATs continued to be low. He was placed on 4 liters of nasal cannula. Patient also has a history of smoking cigarettes and drinking alcohol on a daily basis. 4 days prior to this ER visit, the patient had recently been to an outdoor concert event with his friends. His vital signs are blood pressure of 90/65, pulse is 120, sinus tach. Respirations are 26 with equal chest rise and fall. Temperature is 100.3 oral. SATs are 95% on 4 liters of nasal cannula. His weight is 133 kilograms and his height is 65 inches. His physical exam, his patient is awake but he's lethargic. His skin is pale and diaphoretic. He does have mottled skin noted on the underside of where he was found laying on the floor. Respirations are labored with increased work of breathing. Retractions are noted. Lung sounds are coarse bilaterally. There's a cough that's noted that's productive with slight yellow sputum. His cap refill is more than 3 seconds. Cardiac monitor notes the sinus tach at a rate of 120. His patient's urine has been dark yellow to amber color, and he has voided 200 mLs. The workup for this patient is adjuncts. The patient will have a cardiac monitor, continuous SpO2, BP monitor. 2 large bore IVs are placed in his extremities, and a rectal temp. Labs consist of CBC, a CMP, a troponin due to his chest pain, ABGs due to his shortness of breath, blood cultures due to his fever, lactic acid due to his symptoms and a fever, SED rate, serum CK due to being on the floor, potentially for rhabdo, PT, a PTT to check for his bleeding time, D-dimer due to his chest pain to check to see if he potentially has a blood clot, and also with his altered mental status we need a glucose finger stick. Also, we'll check for the COVID-19 biofire that checks for several different respiratory issues, RSV, flu, just to name a few. He's also going to get an EKG, a portable chest x-ray, a CT of the head due to his altered mental status. A portable chest will be to define whether to see his lungs. And then if his D-dimer is elevated, the patient will need a CT of the chest with contrast to rule out a PE. Differential diagnoses that I've come up with for this patient is acute bronchitis, which this information is provided from the up-to-date website titled Acute Bronchitis in Adults. It is noted that with acute bronchitis, they have an acute cough, and it's usually productive. It's also a viral syndrome, and it can be resolved in a week. Lungs are usually treated with over-the-counter medication and symptomatic care. Causes of acute bronchitis could be flu, RSV, COVID, just to name a few. Due to the patient having signs and symptoms of fever and tachypnea, this rules the patient out for acute bronchitis, and that is according to the information of acute bronchitis in adults. Chest x-rays for acute bronchitis are usually normal. Lab tests, testing for a specific pathogen is usually not needed because it does not change the fact of how you would manage this patient. Gram stain and bacterial cultures of the sputum are usually not recommended because bacterial pathogens are rare causes of acute bronchitis. For acute bronchitis, over-the-counter medications would be used, could include dextromethorphan or guaifenesin. If the patient is taking SSRI, then they will need to be careful with the dextromethorphan. Also, you do not want to use opioid cough suppressants with such as guaifenesin and codeine due to their potential to be addictive. Albuterol neb treatments or inhalers should only be used for patients that are wheezing. Ibuprofen and oral steroids, herbal remedies for cough, for acute bronchitis are things that should not be used due to the lack of efficacy, and you also think of safety concerns with herbal remedies mixing with different medications. Ibuprofen and steroids were not shown to be any more effective with the cough. Also, with acute bronchitis, you want to avoid using antibiotics over and over. My next differential diagnosis is community-acquired pneumonia, and information on this was received from up-to-date treatment of community-acquired pneumonia in adults in the outpatient setting. The big thing on this is to obtain an accurate diagnosis and then determining the treatment setting and whether or not to start antibiotics promptly. That is the essential for community-acquired pneumonia. Once that's determined and treatment is started, then you need to decide whether or not the patient is admitted or discharged. Establishing a diagnosis can also be confirmed with a chest x-ray and signs of fever, cough, dyspnea, and the cough is usually productive. Once we've confirmed that it's pneumonia, then we need to use an empiric antibiotic treatment. Important pathogens that you can keep in mind with a community-acquired pneumonia would be Legionella species, tuberculosis, influenza A and B, RSV. Those are just to name a few. Empiric regimen medications are designed to cover most common bacterial causes of community-acquired pneumonia, and that would be azithromycin, 500 milligrams daily for 3 days would be the choice of medication to treat for community-acquired pneumonia. Patients should be afebrile for more than 48 hours and clinically stable, and then you can discontinue your therapy. Once the pneumonia diagnosis has been made, treatment is started, patient is discharged, he or she will need to be followed up in 24 to 48 hours to reassess his prognosis. If they are not responding to therapy after 48 to 72 hours, there again they need to be reevaluated, potentially change antibiotic, and then reevaluated again. My next differential diagnosis will be rhabdomyolysis, and that information is from up to date. titled Clinical Manifestations and Diagnosis of Rhabdomyolysis. Rhabdomyolysis is characterized by muscle necrosis from the CK level. The triad symptoms of rhabdomyolysis is muscle aches, weakness, and urine colored red or brown. And then also you will have an elevated CK level. Other signs that can be included with rhabdo is fever, altered mental status, tachycardia, malaise. Those are symptoms that this patient is portraying. Muscle swelling and tenderness definitely needs to be assessed. Skin change, colors, discoloration, blisters may be found. Lab findings would be an elevated CK. You're going to see the urine is going to be a red-brown color. That's due to the myoglobin in the urine. Routine labs would be sed rate, C-reactive protein, CBC. CK levels can actually rise within 2 to 12 hours post muscle injury, and they can max out at 24 to 72 hours. It may actually take 3 to 5 days to see a decrease in the CK level. Hypovolemia and decreased electrolytes are normal findings of rhabdo. To treat those hypovolemia, you're going to use normal saline infusions. The hypovolemia is due to the third spacing that occurs with the rhabdo and injured muscles. Hyperkalemia and hyperphosphatemia. The hyperkalemia, that happens because of the potassium and phosphorus that is released into the bloodstream from the damaged muscles. So therefore you will have to do probably a potassium shift. Those medications would include insulin and dextrose. Could use albuterol to help with hyperkalemia and also with fluids. Metabolic acidosis is common, and that would be evaluated with ABGs. Management would be fluids and electrolyte to reestablish those. Prompt recognition, evaluation, and treatment of compartment syndrome due to the swelling of the muscle is imperative for this. My fourth differential diagnosis is sepsis, and that is from up-to-date evaluation and management of suspected sepsis and septic shock in adults. Due to this patient portraying a fever, sputum, productive cough, having signs of pneumonia, then he has tachypnea, tachycardia, and a decreased low blood pressure. Those are signs and symptoms of sepsis. It's imperative to start a 1-hour bundle once sepsis is detected, and that's again with your large bore IV, normal saline 30 mLs per kilogram infusion. Blood cultures are drawn, antibiotics are started, mostly a broad spectrum antibiotic, and we're going to go with Rocephin 1 gram piggyback, and that can be followed with 500 azithromycin IV piggyback. My diagnosis and treatment for this patient is going to be he is septic due to the signs and symptoms of fever and a source of infection from the pneumonia. He has hypotension, tachycardia, and elevated white count. The normal saline fluid infusion of 30 mLs per K within 1 hour of starting. We've started some antibiotics. Upon this one, we're going to do Zosyn 3.375 piggyback after the blood cultures are drawn from 2 different sites. If the patient continues to have a decreased blood pressure of a MAP less than 65, we're going to start a vasopressor of medication of Levophed, 8 milligrams and 250 normal saline, and we're going to start that at 2 micrograms per kilogram per minute. That's going to be added to the order. Then we're going to titrate that to keep a mean arterial pressure of 60 to 70 and a urine output of more than 0.5 mLs per kilogram per hour. Due to the patient having the Levophed started, he will need to have a central line placement, triple lumen. That has been ordered, and the physician has placed that. The patient will need a chest x-ray post-procedure of the central line to check for placement and for pneumothorax. Upon admission to the ICU, he has requested to be a full code. The patient stated that his religion is Baptist. His admit orders would be to continue his cardiac monitor, blood pressure, SpO2. Lactic acid will need to be drawn every 6 hours. His daily labs would consist of a CBC, CMP, ABGs, Zosyn 3.375, IV piggyback every 6 hours, a normal saline 1 liter at 75 mLs an hour. Up to date did state no difference in mortality with fluids infusing fast during an admission. His oxygen is going to be titrated to keep SATs above 92%. If they continue to drop or he deteriorates, we will consider BiPAP or possibly intubation. Once this patient is responding to therapy, then we are going to decrease or stop the fluid infusion. We're going to wean him off the vasopressor of Levophed, and then he possibly will need some diuretics. We could include Lasix for that. The antibiotics will be narrowed down once the blood culture results are back and we see what the medication is susceptible according to the blood cultures. Antibiotics will need to be continued for 7 to 10 days. Upon discharge, after the patient has been moved to the med-surg floor, he's been there, treated, ready to go home, I will recommend this patient to do a 4-week strength rehab post-discharge due to his decreased ability to perform ADLs and his weakness. Also going to talk to this patient about healthier living style, decreasing his smoking, his alcohol intake, and getting to a healthier weight by making more healthier food choices. That is all that I have for this patient, and thank you very much. Bye.